Today's technique has to do with implant bar repair. We get a lot of these from cases that we inherit through new accounts, basically. At least that's the way I get them. New doctor, and then I inherit all the things that were done prior to my introduction to the doctor. So implant bar repair, bar weld, and tooth reset, a pretty basic one that comes along from time to time because basic rules of construction are ignored, and obviously at some place down the line we get a consequent failure. So I'm going to show you just a real quick one on how I attack the situation in the least labor-intensive fashion when presented with very few options, and the few options being, of course, that they want to continue to use the bar that's fractured. So if you get a chance, by the way, Zaleske's Online Removable Study Club, that's me, over at Facebook. If you don't belong to 325 groups and you'd like to participate and you fabricate removable prosthetics, make a request and we'll see if we can't squeeze you in there. And you can also contact me if you're a doctor or a patient looking for me to work with one of their doctors at matrixdental@comcast.net, and you can contact me there. I want to also thank you for tuning into my channel, and please subscribe if you're stopping by for a first time. You'll get an update every time I post a video. They're not earth-shattering videos. They're things that get your mind working, show you the way I do things, and then obviously you can modify those to fit your situation. So if you get a chance, please subscribe, and hey, if you like what you saw, please give me a like. It's good for my ego. So here's a case, existing condition comes in, and you can see that first off, the first thing I see right off the bat is that we have 1, 2, 3, 4, 5 implants, and they're all very anteriorly placed, and we've got this huge cantilever back here on both sides, basically, that really goes outside the AP spread rules, and we'll talk about those in a second. But this is how it comes in. I put it on the model and do some evaluations, make some notes like I just mentioned here. Give you another picture of it. You can see this side's pretty well beat up and flat. This is the side that fractured. You could see they had a fracture and put a little bit of acrylic in there to get them through till I guess they could get in to surrender the bar. So anyways, it's mounted up, and I'm evaluating everything, looking at the occlusal schemes. I don't want to change anything, except I just want to repair this segment. So, you know, I have to take a very good look. You'll notice I have some indices on here that I placed. I'll show you what I do with those two in a minute. Here's the outside of the AP spread. You can see the amount of cantilever. You can also see the amount of crap underneath here. Not much I can do about the recontouring it. I called and asked, and recontouring was out of the question. But you can see that there was quite a bit of collection underneath because there was a concavity between each one of these. I would have rounded these out and asked to, but there was some concern about food, which is kind of foolish, but food trapping and so forth. So, you know, I just move along, take a look at this up close, and I notice, and I let my clinical partner know that the last abutment has sheared on the cylinder, and that I would recommend a complete rework, new bar, so on and so forth, and they weren't interested. So I try to document everything as I go along and took pictures of this just to show the difference in the spread and how far it exceeded and where it broke. And if you're not sure about AP spread or the rules, there are some basic rules, and that is you take a measurement from the front of implant, depending on the configuration. If there was only 4, then you would take obviously the measurement between the top of the anterior 2, and then you take a measurement back here on the terminal implants, and that distance between the front and the back times 1.5 is basically where the terminus of the implant supported bar should exist. Here's another case, pretty similar setup, center, anterior implant, and then 2 on either side of the midline. And basically the rule goes kind of like this. Some people take the measurement from the anterior part of the implant, some from the posterior. I've read and I take into account straight down the middle, and then I'll use the distal portion of the implant to take my A measurement. And then once I've taken my A measurement, I can go, or I suggest, 1.5 or 1.5 times this distance to the terminus. I cannot and I will not warranty anything that exceeds AP spread. There are some feelings that if you had opposing natural dentition, that you have to hold rather fast to it, and if you have a denture opposing it, that you've got a little bit of wiggle room. But where do you stop your wiggle room, and where do you put your foot down? And so 1.5 times the AP spread for me is the way I roll. If you have an angulation where one is further distal than the other, just remember that that distance will increase back this way as well as this one. And so if this one's further back, you're not going to go as far back because it's still going to only be 1.5 times that distance. Okay. And again, there's plenty of authors on this, many authors on this topic. You have to choose one, embrace it, and then you have to build your policy around it. I do this. I don't know if I'm going to encounter in the course of fabricating the case. So one of the things that I'll do is I'll take, like I showed you earlier, put index marks on the front of the model, and then I'll cover the entire thing in position with putty. This maintains my tooth positions. I never know what's going to happen in the course of the repair and fabrication. So like I say, I like to save all the positions and throw it to the side. It doesn't take me just a buck or two to make a putty index like this. So if I need to, I haven't lost any of the positions. I know I have an opposing model and so forth, but I always just feel safe whenever I save positions. So this would be the GCLT putty I use here on this case. One of the other things I do is that before I cut away all the acrylic to expose the fracture, what I did was I mixed up some putty, the same putty, GCLT putty, placed it over the saddle, and then I placed the bar back over the top, making sure that it didn't flex or move, and screwed it down. The putty was very soft, and I was able to index it. And the reason I do this is because this basically will hold everything in position. It also keeps the saddle up off the model, and I'm going to be saving the saddle and only removing the teeth to reset the case. So by placing the putty underneath, letting it set up before I take it all apart, I have a way to index the tissue area when it comes back repaired, so that I'll have a identical approximation that I had before it was all taken apart and welded. Okay. Fractured at the cylinder, just to show you again how nasty that was, right down the cylinder. And again, I took these pictures, sent them off to my clinical partner, and he wanted me to do the best I could with what I had. And again, you can see the amount of cantilever. There's just another picture to show you the shear. I like to document everything with photographs for my own benefit. Then I sent this off to my buddy Bob Hicks at Hicks Dental Lab in Port Huron, Michigan, and he's an excellent welder. He gives BTI courses and so forth for laser welding, and he puts down like little nano nickels, I call them, because good welding is a bunch of nickels or dimes laid on top of each other to make a good weld. Well, he can take that laser welder and just lay down a beautiful weld for me, which he did. Again, took a picture. I gave him that model along with the support putty underneath so we didn't lose the index. And he went to town on this. And again, find yourself somebody who knows his stuff about laser welding. If you don't have one yourself, he can be a good benefit for you in these kind of situations. Again, even though we have laser welded it, there is no warranty on this because this is a repair. And there are existing conditions which cause this to occur. Then I get it back, put it back on the model, mount it up against its opposing, and I remove all the teeth, but only the teeth from the repair back. And I do not take off the tissue bearing area. I'll show you here in a minute, but I have the tissue area which I leave. I just scallop all the teeth off, and then I'll set new teeth on that and final wax it. And when I do that, I put a little dowel, a little metal dowel down the hole to block the hole, because I'm going to block that hole when I process so that I don't get any acrylic on top of the screw. Again, you can see the setup. It's been articulated and set with new teeth and wax from here all the way across. I encompass this area with new wax as well. And that'll be new acrylic also. Here's the saddle area. Just took a zoomed in to show you. I scalloped all the teeth off it, but you'll notice I left the underside, and this is basically a saddle which I can set the teeth on top of. So then I fill this access hole with this 5/16 shaft or similar, whatever the hole size is. Wax it all in place, and then I'll flask the case. I show you this because this is in place before I flask it. I didn't have a picture of this case flasked at this point, but from this line, well, from that line, let's go back this way. From this line forward, this is all covered with stone. The only thing that I have, the only things that I leave out of the stone is anything that's going to be waxed and be washed out, because I don't need to have any of this stuff exposed. I just need to process this area on top of what I've accomplished here. And that's a split flask reline technique. I'll show you this in a second. Here it is, washed out and prepared. You see the saddle, it's still intact. I washed out everything here. Here's my cuspid and my 3 teeth, 2 bicuspids and a molar. Put a little retentive groove here and put a little groove in this one. You'll notice that I have this little, this is liquid latex. This is a rubber sep. And the reason I put that on there is because when I opened the flask after I washed it out, I had a little bit of a catch, and I got like a little fracture line right here in the top of the first pour. So I covered it with that product so that I wouldn't have any acrylic stick in anything or get jammed down in there around the teeth. But what is exposed is the shaft and the saddle, and that's all washed clean, and here's the secondary half of it. Here's another view of it. You can see, I mean, you know, I had a bad catch and it kind of cracked this here, so I just laid rubber sep right on top of it to keep it from being an issue. Even the corner of the tooth right here, you can see it. Really not that concerned because the rubber sep isolates it. Also what I do is I take that shank that I've put in the hole, and I'll take it out and I'll dip it in a little bit of rubber sep, and then I'll push it back down in the hole, and what it will do is it will form a seam to seal off any chance of any acrylic getting down into that screw access hole. Okay. You'll also notice that I have some e-glass fiber that I placed down in this area. I'm a big believer in polyaramid fibers, and I wanted to make sure that I reinforce the acrylic between the acrylic that's new and old. So I just put a little bit of that product in there. You could use Stick Tech from GC. There's several out there. This was just some e-glass I had laying around, so I laid it in there. It's silanated, which helps it bond to the acrylic. Place that in there. And this is the other side. You can again see the old saddle, and it's been washed out. And now I'll go ahead and pack the case and process it. Trial pack at 1,000 psi, a final closure at 2,500. I cured this with the GC Nature Krill Super High Impact. I did it for 8 hours, and then I deflask, and then I finished the case. When I'm removing the shank, or when I'm deflasking and finishing the case, it's a mess. As you can see, there is some flash. The cool thing is, remember that this isn't really adhering here. I have a separator on there, and it doesn't really bond to the tooth. If it does, you just take a little, I have like a little chisel, and I just take and kind of wedge it underneath, and it pops right off. But anyways, I'll finish this area off, and in here I'll grab the pin with some specialized pliers that I made for pulling pins from these type of cases. It kind of looks like that. It facilitates a better purchase on a small shank and modified a pair of pliers. Basically, I just took a disc and cut it like this to give it little fingers, which help, or little spines or fingers, so I could grab the shank end. Here's a completed case. I'm not going to fidget with this. I asked if I could clean it up and reshape and modify it, and I was told that he wasn't interested, and so okay, fine. You know, I mean, I can only ask, and again, I cannot warranty this repair because there are certain, like I say, certain things here, conditions, which will prevent me from warrantying it. And the other thing is, I should probably mention, is I don't warranty other people's work. It's a repair, and a repair is to fix something that was wrong to begin with, usually, and I'm not going to embrace somebody else's work and have an endless stream of repairs on somebody else's work. So anyways, this is the bottom side, this is the back side. You can see this is, from here over is the new acrylic. Here it is mounted and equilibrated. It's all fresh and new. I'll show you what I did, but I did convince the doctor to cut the molar in half to eliminate a bit of the cantilever. He wouldn't allow me to do it on the other side, but on this side he was allowed to, for me to make that about the width of a bicuspid. So it's almost like we have 3 bicuspids. So what? We took off about half a tooth. You know, I'm hoping that is going to help the case along. You know, these cases, they need to be really planned out ahead of time, and I know it's difficult for a clinician to talk a patient into second bicuspid occlusion, so, or an implant. And you know, in these cases here, these the implants are placed. You can't go back, you know, 10 years later and put another implant in, or patients aren't going to put up with it. But you know, so we have to work with what we have. And so what we had was an extended distance, and I at least talked him into a half a molar. The acrylic really polishes up really nice. You can see it looks exceptional. It's an exceptional repair. There it is off the model and underneath, so you can see exactly what's going on. You can see my half a molar. And again, nothing fancy here. It's a repair. No need to do any characterization or anything. I just want to get it done, make it last and hold up. And I'm hoping with the e-glass in there and with Bob Hicks's professional repair, that'll last. Well, this case, I think, is, I'm not mistaken, it's 5 years old, and I haven't seen it yet. 4 years old. I haven't seen it yet. So, you know, so far so good. Fingers are crossed. But if it comes back, I have not warrantied it, so it will be another fee unless we go to facilitate a brand new bar. So here's kind of like the steps, the welds, Bob's welds, and then the process from the back side, the process from the front side, and the underneath side. And again, that's Hicks Dental Lab, who does the laser welding for me, or has done laser welding for me, and GC America for the Nature Acryl Super High Impact acrylic. I can't say enough about good stuff about their acrylic. It's outstanding. If you get a chance, you ought to try. If not their Super High Impact, the microwave version of that acrylic, it's awesome. Anyways, I want to thank you for stopping by today. Take a look at this video. I hope you got some ideas on repairs. Maybe one or two little things that I've done that maybe help you through your next repair. So again, thank you very much for visiting my channel. Give me a like if you can, and please subscribe if you haven't. And look forward to meeting with you again here on another occasion. Have a great day.